this. So I can close that one. How do I get to my
Here, PowerPoint presentation.
At the top, Monday.
Sorry. I have a Mac. Okay. Good. First, I'd like to say that I have no financial conflicts of interest in any of the devices in this presentation. I work at the VA, therefore, by definition, I have no conflicts of interest in any devices in the presentation. Glaucoma remains one of the most common blinding conditions in ophthalmology. For several decades, the common treatment paradigm has been to treat primary open-angle glaucoma first with medications, usually in drop form. If medications failed, then we resorted to surgery, to laser therapy, and then if that failed, we resorted to surgery. The treatment paradigm changed somewhat in the 90s as the British first started doing surgery earlier, and then it started to change again when there came some data that laser treatment first was effective. But then with the introduction of the prostaglandin analogs in the mid-90s, we basically went pretty much back to the paradigm of drops first, then laser, then surgery if all else failed. The title of my talk is MIGS Adventures at the Kansas City VA. I'll leave you to decide how adventurous this is. Anyway, then along came MIGS surgery. Ike Ahmed described what that consists of. I found two different references on the timing, either 2009 or 2012. But basically, it means an ab internal incision. It means a biocompatible device with minimal disruption of the anatomy and physiology. It means a high safety profile. It should be effective in lowering the intraocular pressure, and there should be a quick recovery time. The joke all along about minimally invasive glaucoma surgery is it MIGS or is it really MEGS? Is it just minimally effective? But the goals of MIGS were, as I stated, to be safe, effective, and minimally disruptive to the tissue. So why MIGS? What's wrong with our current treatment paradigm? Well, let's talk about medications first. And we all know these. There's compliance problems. All of our medications cause ocular surface disease. There's the cost of medications. This is not a real big problem with most of them being generics now, but with the introduction of new medications like Natarzadil, we got to re-experience the sticker shock that we all felt in the 90s when all the prostaglandins first came out. There is demonstrated damage to the conjunctiva by medications, potentially the outflow tract. You might even be making glaucoma worse by treating glaucoma with medications. Now, there is the possibility that new delivery systems could alleviate some of these problems. Who knows if that means that our glaucoma practice of the future will look different? Will we be having patients come in every 3 months to get injections, so we'll become kind of like the retina doctors are now? Okay, that's medications. What about surgery? Well, we all know the problems with glaucoma surgery. Let's start with trabeculectomy, bleb leaks, hypotony, flat chambers, choroidal effusions, blebitis, hypotony, and cataract. And I've got a few slides here just to go through some of these pictures. There's a nice bleb leak. There's actually fairly modest choroidal effusions. I wouldn't be that concerned about those. And there's a classic case of blebitis with a white bleb surrounded by a very inflamed conjunctiva. Well, tube shunts became more popular beginning in the 90s, and they've become even more popular with the TVT study, the tube versus trabeculectomy study. So what's wrong with just doing tube shunts on everybody? Well, they have their own problems too. They can erode, they cause double vision, they can cause corneal decompensation, and almost always after tube shunt surgery, medications are still required. So again, we've got some pictures of that. There's a tube that's eroded, and there's a tube that's too long and touching the central cornea, causing corneal edema. So our current treatments, while they're effective, are not without their own problems. So why do we want to think about doing some other kind of surgery like MIGS? Well, can we treat mild to moderate glaucoma earlier and prevent severe visual loss? Can we decrease the cost and burden of medications? Everybody who's done much glaucoma is amazed at the gratefulness of patients when we get them off of medications. They're so happy to be off of their medications. Doesn't happen very often, but when they are, they're very grateful. There is some evidence that surgery, both laser and incisional surgery, may actually improve the diurnal IOP curve. And so it's possible that we may actually be making the glaucoma better by doing something surgical. And then, since we do a lot of cataract surgery, that's an ideal time to add MIGS procedures, what has been called cataract plus in the past. So there's MIGS types. I'm just going to go through these quickly in the interest of time. Basically, they're divided up into trabecular, supraciliary, subconjunctival procedures that affect aqueous inflow, and then cataract surgery alone can often lower the pressure somewhat. So here's a list of the trabecular ones, most of which we're familiar with and perform, starting with the trabectome, and now the hydrous stent is available with all the various goniotomy techniques included. Here's some of the other types of procedures. The CyPass was the first approved supraciliary device. The Zen gel stent is available for subconjunctival, a subconjunctival device. We don't have much for aqueous inflow. There's ECP, endocyclophotocoagulation. We personally don't have access to that at the VA, so I don't have that much experience with it. And I just included micropulse CPC to be complete. So what is our history at the Kansas City VA of doing MIGS? Well, the first year we had eye stents on the shelf, so that's what we did. We did eye stents along with cataract surgery. The second year we added canaloplasty ab interno because I was convinced that it had some more beneficial effects than the eye stent. We also added the CyPass because we thought the CyPass would be an ideal procedure to teach comprehensive ophthalmologists doing cataract surgery. And it was an easy procedure to learn. Unfortunately, it had other problems. The third year, we added the Cahook dual blade, and mostly we did that because that's when the CyPass went away. This year, we were going to add the Zen gel stent, and unfortunately, the COVID-19 pandemic got in the way of that. We haven't done our first case of it yet, and it probably means I'll have to take the wet lab again for the umpteenth time. Okay, MIGS at the Kansas City VA is a little bit unique from what you will often read about in the literature. First of all, the residents perform the majority of the surgery. I have observed that the eye stent was probably the most technically difficult to do to get in the right place. The CyPass was obviously the easiest, but led to the greatest problems. Canaloplasty is difficult, but it is easy to tell when the catheter's in Schlemm's canal once you get it there. And all of the residents that have done it so far have been able to accomplish doing at least a few of these procedures. At the VA, we almost always combine it with cataract surgery. And just looking at how the evolution of our treatment went at the VA, we started out doing eye stents for mild to moderate disease. Then we went to CyPass. When the CyPass was recalled, we went to the Cahook dual blade. For more severe cases, we've been trying to do some canaloplasty, and we did a few GAT procedures, gonioscopically assisted transluminal trabeculotomy, which is why you abbreviate it GAT. Okay, so let's look at our actual results. Here's the eye stent. Here's a picture of the eye stent, nicely placed in the trabecular meshwork. We've done a lot of eye stents for the sake of this presentation. I just looked at the procedures that we did for the academic year of 2017 to 2018 because I kept very close data on that particular year. Between July of 17 and March of 18, we did 37 iStent procedures, and I have 1 year data on 33 of them. All of them were done with cataract surgery, obviously, because that was required with when it was FDA approved. All were for mild to moderate glaucoma, again, because that was an FDA requirement. We only did any single iStents. We did not do any multiple iStents. I know there were people around the country, even at VAs, that did multiple iStents, but we would have had to get those approved on a case-by-case basis, which would have taken forever, so we didn't do any multiples. Here's our results. Our pre-op pressure in those 33 patients was 18.2, and they were on 1.3 medications on average. At 1 year, their post-op pressure was 17.2, and they were on 0.7 medicine. So we basically had a 5% drop on half a medicine less. This doesn't sound very good. It's not very good. It's pretty underwhelming. The published results, though, are really not a whole lot different. The original study done by Samuelson showed that in their patients having cataract surgery with or without iStent, 15% of the people that had iStent were off of were still on meds, rather, whereas 35% of the people that just had cataract surgery were still on meds. But when you look at their mean pressure reduction, they only had a drop of 1.5 millimeters of mercury with the iStents. A Cochrane database review basically said that when you look at the data, there's very little drop in intraocular pressure, and there's a modest decrease in number of medications. There have been some other studies, but still, they're all in this ballpark range of improvement. I thought it would be interesting to look at how these devices, not only how they work effectively on glaucoma, but how much they how well they do in cost-benefit analysis. So the iStent, because we're a hospital outpatient department, cost us over $2,200. It's not that much at a surgery center. And since we improved 1 millimeter of mercury per iStent, that means it cost us $2,200 per millimeter of mercury. We had a modest savings on medications, and I took the generic cost of our 4 most common medications off of the internet to calculate this figure. And I figured out that the number of months to recoup the cost of the device was 343, which is basically about as long as your average home mortgage, which isn't very good for 1 meter of mercury. So we're not doing a lot of iStents anymore. Okay, let's look at canaloplasty. I'll just quickly show a little bit of this video. Residents know I'm doing this because I think it's kind of cool. But here we are, first making an incision in the anterior trabecular meshwork with a 26 gauge needle under gonioscopy, under a gonio lens. But we can move around that. And when we go forward, you can see the blinking light there is the end of the actual catheter. So here's an MST forceps. We're going to pass the catheter into Schlemm's canal, and you'll be able to see the red blinking light. Oh, that gets in the way. So you can see the blinking light there in the trabecular meshwork. In a moment, you'll start to see it appear over here as it goes around in Schlemm's canal all the way around the eye. And basically, you put it in like this, and then as you pull it out, you just go dilate the canal. So what were our results? We have 33 procedures that we did between July of 2017 and September of 2018, have 1 year data on 31 of those. The vast majority were done with cataract surgery. The main difference in canaloplasty versus the other procedures I'm going to present is that the majority of them were actually done for severe glaucoma. Only about a third were done for more mild to moderate disease. The results are sort of backwards here, so let's look at our results first. Our pre-op pressure was 17.1 on 2.6 meds. And 1 year post-op pressure was 13.5 on 1.5 meds, which represents a 21% drop on a little over one medication less. That doesn't look all that great, but it is 20%, which isn't bad. And you know, if I could get every glaucoma patient I see down to a pressure of 13.5, I think I would be doing them a favor. The published results, at least recent published results, are actually better than that, with a decrease of more like 30 or 33%. And these two studies I've got noted up there. Part of that is because start out with higher pressure. In all of glaucoma, if you start out with a higher pressure, you've got a far you can drop, and so that tends to give you better results just by doing that. But their published results were definitely a little better than ours. Although you notice that the ultimate pressure, average pressure they got down to was really not a lot different from ours. So here's another way of looking at the results. 60% had a 20% drop in the pressure. 70% had a final pressure less than 15, which is, you know, if you want severe disease down in the low teens, we're accomplishing that 70% of the time. 58% got off at least one medication. And when you look at a couple of different ways of looking at the success of this, 76% either had a 20% drop in pressure or got off one medication or both. So it's not perfect, but it's not bad. Complications, we had hyphemas, a couple of decimated detachments that resolved, some cystoid macular edema, pressure spikes in a couple of patients, one of which had an express shunt, and the other resolved on its own with medical treatment. We've had a run, there's only one in this group of patients, but we've had a few where we were unable to pass the catheter, usually due to visualization after the cataract surgery. We just couldn't see the all that well. So cost of the device. Well, it cost us a lot less than the iStent, only $995. Cost per millimeter of mercury is a little more reasonable, $275. We actually saved almost $12 a month on this, and so the number of months to recoup the cost of the device was closer to 7 years instead of 30. So let's look at the next procedure we did, CyPass. We did 26 procedures. We had data on 24 of them. The vast majority were mild to moderate glaucoma, and all were done with cataract surgery. The published results showed a 32% decrease in intraocular pressure versus with a medication decrease of 1.2 on average. That was in the big trial where the CyPass was approved. Our results were not quite that good. We had a 19% decrease from a pre-18.6 to 15 on 1/2 medication less. The results with the CyPass seemed better at 6 months, but at a year, the effects seemed to fade some. It was removed from the market for endothelial cell loss, which I'd be glad to talk about if we had more time. It's no longer available, so I didn't do a cost comparison. I will say that we've had to trim 5 of the 26 devices we put in, and we had to remove 1, which was a definite challenge. Although we did get it removed, and the man's chronic uveitis and cystoid macular edema improved. How am I doing on time? Am I going too fast?
A few more minutes.
Okay. Cook dual blade. We did 26 patients. Unfortunately, we only have 6-month data on these people. The vast majority, again, were mild to moderate, and the vast majority were done with cataract surgery. Published a couple of recent studies show about a 4% decrease. Our results, we actually had a 32% decrease. We went from an average pressure of 21.1 down to 14.3. We only got people off medications a modest amount compared to that, but much better results than than what has been published. I suspect that's for 2 reasons. First of all, we had several people that just had really good responses. Over 50% and a 30% decrease in pressure. And then also we didn't get people off medications as much, and so that may be why we had a better response. We had 1 complication, a cyclodialysis, which resolved. We did have, interestingly, 2 patients that had increased pressure of at least 20% that had to be treated with more medications. Cost of device is much less expensive. It's $390, so it only costs us $57 per millimeter of mercury, and given the number of medications we got people off, it takes about 10 years to recoup the cost of the device. So from an effectiveness standpoint, we'd have to say the KDB is the best and the canaloplasty is best from a cost standpoint. Just to compare with major glaucoma surgery, we can get, we have a year of data on, again, the academic year of 2017 and 2018. We had a 50% drop in pressure, which was very effective, but we had the usual complications with major glaucoma surgery, flat chambers and hypotony and so forth. So here's a quick summary comparison. The eye stent, we didn't get very much improvement in the pressure, and we didn't get much decrease in the medicine. We had a better improvement in the pressure with canaloplasty and more decrease in medicines, and a real good improvement in pressure with Cahook dual blade, but not very much medication decrease. So caveats. As I said, the Cahook dual blade was used on milder disease with higher pre-op pressures. Canaloplasty was used on more severe disease. I did a small number of cases with moderate disease on canaloplasty. The results really weren't that much different, so I don't think that made a lot of difference. One thing I will say, goniotomy with anything is a one-shot procedure, whereas canaloplasty is at least theoretically repeatable, and we've had a few people who've done SLT on post-surgery. So my conclusions. First of all, I'd like to congratulate our residents because I think the resident surgery compares favorably with all the published results. So, you know, these are residents first learning how to do this, and they were effective at it. Clearly, the Cahook dual blade was the most effective, and canaloplasty was less effective. I think MIGS is really meant for mild to moderate disease. We were trying to push the envelope a little bit and do severe cases, and I think we really need to just do it for mild to moderate people. Two other things. Don't forget to use mild steroids because there are problems with pressure spikes, and we still need a safer procedure for more severe disease. So, questions? These are my references. Questions?
I think we might need to keep moving along. So thank you so much.